Okay, good morning. So my name is Romain Pirracchio. I'm from UCSF, California, and I had the immense pleasure this morning to present the result of our study called OVISS that was concurrently published in JAMA today. So this study comes from a wide group of people across the United States, at UCSF, at UPMC Pittsburgh, Johns Hopkins, Baltimore. And the goal of this study was actually to try to use and leverage data across a wide variety of networks and use some advanced AI techniques to determine the optimal vasopressin initiation treatment initiation for patients with septic shock. So the idea behind that was that we all know that vasopressin should be used as a second-line agent in patients with septic shock, but the reality is that the guidelines are quite unclear as to when we should actually start. And so there's a very sort of large variety of practices across the globe, and we actually did a survey a couple of years ago with authors from different countries to try to understand when people are starting a second-line vasopressor and which vasopressor they're using. And in the vast majority of the cases, people are using vasopressin, but the reality is that they're using it very differently. Some are using them very early on, some are using them pretty late, and again, there's no consensus in terms of when to actually start it. When we look at the data that was already available, again, there's some variability, and there's a hint that sort of points us towards potentially an improved outcome using vasopressin earlier in septic shock. And that's exactly what we wanted to look at. We wanted to use very large data sets from a broad variety of practices, again, across different networks with a very diverse patient population, and use a specific type of AI called reinforcement learning to try to identify the optimal timing for vasopressin initiation, again, in patients with septic shock that are already treated with a first-line agent, which is norepinephrine in all of those patients. So we were able to access close to 15,000 patients' charts, and we used the data from the UCSF hospital to train this reinforcement learning model. And just to say a few words about this model itself, the way it actually works is that what is called the agent, which is sort of at the core of the reinforcement learning model, the agent will make a decision every hour during 5 days, the first day worth of ICU admission, and will decide during each hour time block whether or not we should start vasopressin. And this decision is based off of different clinical features, and the goal of this decision is to actually optimize what we call the reward function, which encompasses long-term outcomes such as mortality, as well as short-term outcomes such as change in lactate, change in the mean arterial pressure, change in the SOFA score for organ dysfunction, and so on and so forth. So this very complex of the machinery was first trained again in the UCSF data, and then was evaluated in completely external data coming again from different hospital systems, from UPMC, and from two publicly available data sets, namely MIMIC and EICU. And we evaluated the performance of the model in this external data set, and we found that the performance of the model was consistently better, higher than the one obtained with the clinical rules. So in other words, when we compare what was suggested by the model to what was actually done in the data by the clinician, we found that the model was associated with better outcome. And that was confirmed when we actually looked at mortality as an outcome, adjusted for a variety of different possible confounder. We're able to show that following the guidelines from the model was actually associated with a reduction in hospital mortality. Again, this is a retrospective data study in essence, so there is some cautions that we need to apply when interpreting the results. The main one is related to the fact that there's possibly some unmeasured confounding that was not accounted for, although we actually did a very wide range of sensitivity analysis, sort of crash testing the possibility of unmeasured confounders, and we found that across all the sensitivity analysis that we actually performed, the results were pretty solid and robust and consistent, so which is reassuring, but by all means, this study needs to be confirmed with a prospective trial, and so we're currently implementing implementing the model in the UCSF EHR so that we'll be able to hopefully pretty soon start testing the model prospectively, and then the next step will be to run a trial to actually compare the clinical or the clinician-based decision to start vasopressin versus something that would be recommended by the model, and to hopefully show that this type of strategy can in fact prospectively improve the outcome. Thank you.